Hello, good evening, sir.
Good evening, sir. Good evening.
Sir, we will start for 4 to 5 minutes.
Actually, some patient urgency, sir. Will start within 10 minutes, sir. So thank you, sir. You connect on time, sir. Dr. Vivek Prakash again. Thank you, sir. From Sipla side, sir. There is some urgency. Will start within 5 to 10 minutes, sir. Sir, actually, your voice is not coming because you're kindly do unmute yourself, sir. Firstly. Hello. एक सेकंड में फोन कर Very good evening, Doctor, respected Dr. Omkar Singh. I'm Sudhanshu, sir, from Sipla. Good evening, sir. What?
Hello, good evening.
Good evening, sir. Good evening, sir.
Good evening. Good.
Good evening, sir. Good evening, sir. Dr. Omkar Singh. Good evening, sir. Your routine. Good evening, Dr. Pankaj Bansal. Sorry for delay because some emergencies are coming. Doctor, in case PVR, so we'll come in next 10 and 20 minutes, sir. Sorry, sir, for delay, sir. Will
Sudhanshu, I think the sir has joined Dr. Vivek Prakash Agrawal, sir. You can check.
Dr. Agrawal is also joining us. So sorry for delay, sir. Some emergency with Dr. Vivek Prakash Agrawal. So we'll start within 5 to 10 minutes, sir.
Okay. इसके बाद तो ये वाला दिखाई दे। Pranto, am I audible? Good evening.
Yes, sir, audible, sir.
Okay.
Good evening, respected Dr. Vivek Singh. Good evening. Sir, due to some urgency, we'll delay the program because doctor is undergoing the PCR in cath lab. Maybe. Sir, you treat your patient. I call him after some time. I call you, sir. डॉक्टर अभिषेक प्लीज यस सर प्लीज आप सर पेशेंट देख लीजिए मैं आपको कॉल करता हूँ सर
ओके ओके
Pranto, hello. एक बार बात हुई सर से कब तक ज्वाइन करेंगे सर?
सर ज्वाइन कर रहे हैं सर, वो गाउन चेंज करने गए हैं, ओटी से बाहर आ गए हैं, आ रहे हैं सर गाउन चेंज करके।
ओके ओके, थैंक यू। I think once Vivek sir has joined. So, sir, good evening, sir. Nishant here. Vivek sir, good evening. Nishant here.
Good evening.
Oh, actually, we were waiting for you, sir. We got late. I understand, sir. You were busy. You were busy a lot.
Today is basically it's a time consuming. In one case, I have to stuck to more than half an hour. Otherwise, I have to finish to 7 p.m. Okay?
Sir, so no issue. Whenever you say, sir, we can start, sir.
I
As
am
per your
feeling
call.
now. Okay, you can start.
So, sir, we will start soon because we are already running late. So, good evening to all the experts. And on behalf of CIPLA, I take the privilege to welcome you all for this Strengthening Heart Expert Summit. And as you know, this is not like a normal CME where one speaker is presenting and talking to the audience. It is an expert forum, so we request to, it is like a board meeting. So I am expecting that every participation from you all. And during the question answer session, kindly make your video on and kindly keep yourself on mute to participate. And I will not take much time. I will be just introducing moderator for the day, who is Dr. Vivek Prakash Agrawal, sir, from Metro Noida Hospital, and sir is a most senior, very senior intervention cardiologist who has done MBBS, MD, and DM in cardiology, and who has also done various fellowship like FSCI and FESC, FSCC, and CRFC. So, sir, thanks for your availability. Thanks for your time, sir. Now, sir, over to you, sir. Please take it forward. Thank you, sir.
Hello. Good evening, doctors and this team of Sibla team. And this is basically this panel discussion. And I think the expert, Dr. Vivek, Dr. Anwar, and Dr. Omkar Singh, Dr. Prem Bansal, Dr. Didi Sharma, Dr. PK Agarwal. Can you, Nishant, give this some small introduction to all panelists? Hello.
Sir, actually, we have
Okay.
Arun Garg sir from Ghaziabad, who is senior consultant physician. We have Dr. Abhishek Singh sir also, DMB cardiologist from Manipal sir, Ghaziabad, and Dr. Omkar sir also, Omkar Singh. And 2-3 more sir can join, sir, during
Okay,
the.
okay. So that is we have to start. This is the today discussion is the what is as such the MRE placement and utility in heart failure management, and whether the hyperkalemia it is a really concern in physical practice, and to awareness among the physician on the uses of MRA in cases of heart failures. Something we have to tell that the heart failure is a global problem, and 26 million people worldwide affected by the heart failures. And when we have to see the 1 to 2% of population in developed country affected by the heart failure, when we have to considering the age of more than 70%, then this prevalence increase to more than 10%. And we have to for the India 1% population affected by the heart failure, and 10 to 8 million individuals, that is the prevalence in India. And incidence is 0.5 to 1.8 million new cases per year, and mortality is quite high. It is 1.1 to 1.6 million individuals per year. When we have to consider that the mortality, 5 years mortality around 50%, which may be even more than the cancer, just like the prostate cancer, colon cancer, and the breast cancer. That is the come to the point we have to discussion because it is a panel discussion, and right now that this heart failure depend upon the whether it is a there is a new classification of the heart failure, which is called the heart failure with reduced ejection fraction when it is a ejection fraction is less than or equivalent to 40%. The mild reduced ejection fraction when the ejection fraction is 41 to 49%, and the preserved ejection fraction is if it is more than equivalent to 50%. And heart failure with improved new entity is coming, which is says that if the baseline EF increase more than 10 points and the baseline ejection fraction is less than equivalent to 40%, or second measurement is more than 40%. That is the new classification of heart failure. And this is panel discussion. That's first question: what is the heart failure prevalence approach to aneurysm class 2, 3, and 4? How many patients present both undiagnosed in India at early stage? Dr. Anwar, hello.
Good evening, sir.
Good evening. Can you tell me what is your assets in clinical practice? How the number of the heart failure patient is there when we have to comparison, and what are your diagnosis? How we will diagnose?
So basically, we are having in emergency department heart failure patients, and about maximum patients are coming in NYHA class 3 or 4, and very rare patients are coming in NYHA 2 in the emergency department. And basically, we undiagnosed patients are very much far. About 80 to 90% patients are going undiagnosed. Patient giving history about shortness of hypertension, shortness of breath on exertion, and other chest heaviness only, and they are diagnosed and misdiagnosed, by any local health practitioner as case of asthma or COPD, and they come to our emergency department as case of heart failure. Basically, we do BNP levels and other echo 2D echo for diagnosis of heart failure, and other routine investigations for diagnosis of the heart failure patients.
And you are rightly said, because that if we have to the heart failure patient, we have to categorize in the class the A, B, and C, and D. Basically, we have generally they come across the C. The A1, it is only there is no sign of symptom. B, again no sign of symptoms. But in cases of A, is only if the patient having the history of the diabetes, history of this family history of this, maybe you can say CAD, or patient is hypertension, then we have to label as A. And heart failure B is when we have to see the finding of if we have to do the echo, and we have to find out the consenting LVH, and if we have to do the echography, and again the ECG, LVH stain pattern, then it is, but there is no sign and symptom. The class C, then do you have the class symptom, the breathlessness and all, and then depend upon the classification. Generally, if we have to say the heart failure, it is this reduced ejection fraction. And if we have to diagnose the preserved ejection fraction, it is a very difficult in the intent condition that already patient is agitated by the just physicians. So that the heart failure we can say into divided into two groups: acute and the chronic. So basically, the acute failure, then we have to basically decongest the patient. And in this cases, we have to rule off this. You can see the torsemide and the furosemide is there, but not the in the chronic stage. The chronic stage is heart failure. You have to the classification. You have to adding maybe this may be AC inhibitors. Then they are the four pillar of heart failure, the ACE inhibitors or the RNA, AJ2B inhibitors, MRA, and beta blockers. They are the four, this is the diagnostic tool again. And this heart failure is because of whether it is because of any structural heart disease, MR, or maybe aortic stenosis and something on the rheumatic heart failure disease patient, and or maybe it is because of the acute MI which can lead to the this reduced ejection fraction, or maybe this cardiomyopathy. They are the subset of the patient. Then we have to present it. So basically, the diagnostic and prognostic tool when we have to accordingly what is the etiology of the patients. So again, if you have to think for the 2021 update, this consensus, what is the role of the optimization of the heart failure treatment? The position exercise, what is the role of the MRA? The serum potassium concentration is more than 5 milliequivalent per liter, or this in the serum renal injection fraction less than 30 millimol per minute, or the creatinine level is more than 2.5 milligram per deciliter in men, or creatine is more than 2 milligram per deciliter in women. That the question again, are these parameters basically when we have to using the MRA, whether we have to doing the potassium level, creatinine level before the starting of MRA. This question maybe Dr. Abhishek Singh is there.
I'm there.
Yes, sir.
Yeah. Okay. So that if we have to start for the MRA, in case because it is well known this guideline dietary medical therapy. Okay. That this MRA and then the beta blocker, RNA, and the AG2B, but they are the four pillars there.
Yes.
Then we have to start with the MRA, that's potassium level, creatinine level, or GFR. So in our routine practice before starting, whether we have to do these tests or not doing.
Definitely, if we're going to start with this medication, we should know apart from the beneficial effects, we should also know about the implications of the drug or the side effects which can happen in some of the patients while we are giving these drugs. So every drug has some issues related to changes in metabolism. So obviously, this mineralocorticoid receptor antagonists have been known to raise the potassium because they're potassium sparing. So in a patient who is already having CKD or some issues related to his renal functions and is on a higher side of potassium, like if the patient is having a potassium of more than 5, then definitely starting this drug without monitoring it will be a risky thing and can lead to arrhythmias and even cardiac arrest also. So yes, we need to monitor for creatinine levels and potassium levels especially. For creatinine, we say that if the patient is having a creatinine of less than 2.5, we can start with the medicine. And if the potassium is less than 5, in that case also we can start with the drug. And even after starting the drug, if we have seen the baseline and we start with the drug, we'll have to later on follow the patient with the repetition of these tests. That is the rise in the levels of these parameters is significant or not. Because if this drug is causing a significant rise in these levels, we'll have to withdraw the drug, or we will have to transiently hold the drug, do the corrective measures, and then start with it. Also, we'll have to explain to the patient that if the patient is having a higher potassium level, he'll have to avoid fruits and fruit juices, etc. Moreover, basic issue is that ACE, ARBs, or RBs along with mineralocorticoid becomes more of an issue of potassium rise and creatinine rise, because both these groups of drugs are known to cause this. So yes, when we are using this in heart failure patient where both of these drugs are giving us a mortality benefit, we'll have to closely monitor these things to prevent any complications.
You rightly said that because nowadays is maybe the patient again comes with the investigation. So, but first we, if it is a even as such we if it is a acute condition or maybe the hospitalization when we have already doing the KFT, and in the follow up we have to just bring the what is the baseline level, and then we have to measure accordingly, and there is some ligand I will come later on when we have to changing this maybe the we have to stop and when we have to downgrading this MRA. So MRE is recommended if we have to do a classification of the heart failure with reduced ejection fraction. So it is the class 1 indication, and when we have to the reduce mild reduced ejection fraction, then it may be the class 2B indication, which can causing this decreased heart failure, hospitalization, and death. This is the again the algorithm is showing this in the reduced ejection fraction. We have to using either AC inhibitor or RNA beta blocker and MRE and SGLT inhibitors. They are the 4 pillars to treatment of the guideline directed medical therapies. And I have already saying if we have to just decongestion if a patient come with the class 4 this heart failure,
Hello?
then we have to the
Hello?
volume.
Hello?
I am audible. Hello. Hello.
Yeah.
Yeah.
Yes, sir, you are audible. And I request
Okay.
to other when
Okay.
sir is speaking, please keep your audio on.
Okay. No problem. Then we the learning again the torsemide or maybe the frucel like we have to giving to reduce the this volume or with this maybe the Asian beta or beta blockers and MRE. If patient having the LBV or cytosine on the more than 150, then we have to thinking about the CRTD, or if it is ischemic etiology, we have to ICD. I have already said we have to find out what is the etiology again. If patient atrial fibrillation, the class 1 indication is you have to this anticoagulation patients atrial fibrillations. Either you have to diopsine or you will give the pulmonary vein isolation. Again, if the patient is ischemic, we have to either treat it by this bypass surgery or angioplastic because it can improve the what is the cause is there. In if patient is aortostenosis, then we have to either going for the bypass surgery or TAVI. Or if patient is mitral regurgitation, again we have to mitral valve repair or mitral valve clip. We can use if heart rate is more than 70, we have to first using the beta blocker. If it is not controlled by this beta blockers or maybe the conda indication, then we have to using the evaberadine and this black this is the harlazine and esladine may be the beneficial effects. And to reduce ejection fraction to improve the our goal is to improve the quality of life, reduce the hospitalizations and the reduce the death. Again, in what percentage of cases you have to using the MRA in heart failures? And this is Dr. Vivek Agrawal is there.
Yes, sir. Yes, sir. He is there.
Okay. And what is your the expert opinion, Doctor? In what percentage of casing, whether you have to using the 40%, 100%, or 50% in cases, and what is your criteria?
In cases of heart failure,
Yeah, heart failure.
uh,
The patient is already decongested, and they have to come to the your OPD. And how you will manage whether you have to using the MRE or you have entrance because of the side effect of the hyperkalemia is there. Because our consensus whether how much
initially I do prescribe the MRA, but the patient if it develops any symptoms related to the hyperkalemia, then I go for the investigation and get it done. If the potassium level is more than 5.4 or 5.3, then I reduce the dose or ask the patient to take the MRA on alternate day, or if the potassium level is more than 6, then I have to stop the MRA. Absolutely. And first we have to reduce the dose of the potassium level. Then after 1 week or after 2 weeks, again we can start the MRA. Because MRA gives a maximum benefit in cases of the reducing the heart failure.
Hi, Dr. Sir, you are very rightly in saying that we have to using just like a full period of the hypertension, we have to using the MRA unless there is a hindrance, and we have to monitor the potassium level and mainly the potassium level, and accordingly to what is the level, then we have to just either we have downgrading and or maybe the stop and then we have to again start it because it having the mortality benefit and also the decreasing the hospitalizations. The another question: when do you consider starting MRA in patient with heart failure along with ACE inhibitor or beta blockers? And this again, I am asked for Dr. Arun Gar. What is your opinion?
Sir, we have a rest expert also, like Dr. D.D. Sharma has joined, Dr. Pankaj Bansal has joined.
Okay,
If
okay.
we
So,
can ask him.
Dr. Pankaj, just give your view. Hello, Dr. Bansal.
Sir, request you if you are there, sir, please participate, sir. It's a board
Okay,
meeting.
again, maybe the Abhishek Singh.
I think we have a doctor, sir, just a minute. Yeah, Abhishek Singh, sir.
Okay, this is maybe the aldolin skin congestive heart failure. Importance of time initiation of the mineralocorticoid receptor antagonist on the risk of mortality in patient with heart failure. This is the study which is published in 2015. The use MRA is as early as possible on top of treatment, including the ACE beta or ARB, preferably at the discharge after episode of decomposition. That and the following the acute fall in aldosterone in response to administration of ACE inhibitor, the level of aldosterone rises again in the return to baseline in almost all patients. A phenomenon called is aldosterone escape. Even when the ACE inhibitor given combination with the ARB, aldosterone level remain uncontrolled, the aldosterone escape might promote the release of angiotensin 2 via positive feedback loop, stimulate the ACE in the vasculature. And the progressive escape aldosterone are thought to be contribute to the ACE resistance when the effect of the ACE inhibitor become blunted, beneficial of the mortality decrease over the time, where the MRA are able to antagonize the deleterious effect of aldosterone, resulting in a beneficial effect on patient mortality. Again, if we went to comparison whether we have to using the spironolactone and epinephrine, and this is if we have to comparison this eco finding this LV diastolic dimension, systolic and diastolic systolic volume, and this and the end diastolic volume ejection fraction, the epinephrine score over the spironolactone in cases of if we have to the L diastolic diameters and systolic volume ejection fraction, it is the significant. It is better epinephrine better than the spironolactone. When so that is why that if we have to choice whether we have to using the spironolactone, epinephrine, the epinephrine have a score over the spironolactone. Again, that our this panel is already saying the hyperkalemia. This is again if the GFR is more than 50, and we have to using the spironolactone and or maybe with this if 4 to 5.4 there is no adjustment is required. If it is level of 5.5 to 5.9, then we have to decrease the spironolactone dose to half. And again we can if it is already 25, then again we have to alternate it. And if it is more than 6, then we have to stop the MRA, reassess the potassium level for we introduce can give potassium binders. Again, when we have to this potassium level is corrected, then we can reintroduce in a smaller doses. So what is the preferred dose if we have to sing maybe the 25 and 50 milligrams? And the time increase and hello, the outcome in patient with heart failure after acute MI. This is the effects study, which again showing that if using the as compared to after 7 days, there is a or several benefit when we have to start in the 30% reduction in all cause mortality in patient with heart failure, like Implanton versus placebo when we started before 7 days as compared to after 7 days. Again, the sudden death also 30.4% is reduced. Again, that is already saying this when Dr. Pankaj Bansal is there.
Yes, sir, he is there because other experts have
okay.
already participated because it's a board meeting. So Pankaj Bansal sir is there. If you can make a video on and if you can
Just
participate,
I am just
please participate.
Okay, fine. So again, this if we have to going for the therapeutic algorithm as per the guideline directed medical therapy, which is the reduced ejection fraction, we have to using the ACE inhibitor, the RNI, beta blocker, MRA, and the LG2B inhibitors, and the this loop diuretics. The loop diuretics only used, that is this torsemide or the furosemide when we have to decongest the patients. Again, this if this we have to already saying a patient is less than 35% or QRS is more than 150, then we have to using the CRTD, and less than 130 to 149, it is a class 2B indications. Again, the what stage of the heart failure diuretics MRE both are the needed. Again, if a patient is in the acute stages, when we have to using this you can say it is diet or E or maybe something, we have to just decongestion by the torsemide and the ethyl level. Then later on we have to this subtract the diuretics, the furosemide or torsemide, and we can add on and AC inhibitor, RNI or maybe the AC inhibitor or LG2B inhibitors. So again, what is the preferred choice of the therapy? Whether the eplenon plus the torsemide, splenecton plus torsemide. Dr. VK Agrawal is there?
Yeah.
This is Daksha, which is if patient is this decongestion therapy when is required. Patient having the you can see the orthopnea and PNDHT. So whether you have to start the spironolactone or torsemide, or maybe you are more comfortable with Eplenon plus torsemide.
The advantage of eplenon over the spironolactone is only the eplenon does not cause the gynecomastia as the spironolactone causes. This is the only advantage which I have observed. Otherwise, the effect is not very different of eplenon from the spironolactone. Whether you add the spironolactone or you add the eplenon to the torsemide or the furosemide. With the torsemide, you get less hyponatremia. Otherwise,
you are rightly said. Whether we have to using, but this if we have to the abscess study and all these things, this is if we cover the spinal electron, definitely the gynecomastia is the main concern with the spinal electrons.
So I would like to add here, Dr. Vivek Agrawal sir from Agra. He is a good user of eplenon. Thank you, sir.
Daksha, I am this MD medicine from the SNM Metricology Agra.
Yes, sir. Dr. Vivek Agrawal sir from Agra.
Okay. And this is any indication. I am just asking the panelists, any other indication you have to think for this MRE other than the heart failure?
in cases of resistant hypertension, also we can give it.
Yeah, right. You have rightly said. Okay. And we can, because in the eastern hypertension we can use that. And Okay, fine. And that is already this some Nishant you have to giving because this MRA and the rituximab the combination is 10 to 25. Whether you have because there is the later on there is no role of maybe the torsemide. Whether you are coming with the lower doses of torsemide with epinol combination in future. Hello, hello.
So you are audible.
Acha, Mr. Nishant, or maybe the Sibla, I am just asking that this already you have to come with the if you have to thinking for the Ditor Plus or something else, then they have to come with the 5, 10, and 20. Whether you have to coming with torsemide, this torsemide is coming Ditor E, or maybe with the lower doses because after this decongestion, we have not to require the maybe this diuretics maybe the prosamide or the torsemide, we have to only the MRE, the already we have the LG2 inhibitors again causing the water depletion. So basically, then when we have to just the decongestion is gone, then we have to switch over because the furpilary is the maybe the beta blocker RD again and the AJ2B inhibitors and the MRA. So we there is a very less role of this diuretics and the only the decongestion. So whether any combination you have to coming with lower doses of this torsamides. This is question again. This is for this. The what scientific initiative would you suggest is maybe the any this coming is there and only what maybe the scientific initiative you have to just anything you have to suggest. I am just asking that was Abhishek.
Actually, single drug epinol will be a welcome thing because in patients of resistant hypertension, there is a situation where you need it as a single drug without a combination with a torsemide or a furosemide. So yes, that will be a welcome thing. And regarding the communication to the GPs or other physicians, they'll have to give the data in printed form that these are the benefits these heart failure patients or resistant hypertension patients or primary aldosteronism patients are getting with this drug to let them get the confidence to write this drug with more emphasis and in more numbers.
Okay, fine. Thank you to all the panelists.
So thank you, Dr. Vivek Prakash Agrawal, provide the valuable opinion and also again thank you कि इतना मतलब वेट करने के बाद भी हमारे डॉक्टर्स कनेक्ट रहे एंड थैंक यू सो डॉक्टर अभिषेक सिंह अगेन डॉक्टर वीके अग्रवाल हार्डली थैंक्स टू यू सर and also our president Dr. Arun Garg hardly thank you again and Dr. Pankaj Balsal. Number of audience is because left due to the some time issue, but again side of Cipla again thank you to audience and it's a very wonderful session without you this is not create a wonderful session. All questions depend on your daily practice and your opinion is also helpful for us and this recording to share by HO office and again see the इसमें से क्या क्रिस हम निकाल सकते हैं और क्या हम इसको बेटर कर सकते हैं अपने आने वाले टाइम में सिप्ला के लिए तो अगेन सर थैंक यू सर थैंक यू सो मच सर
Okay.
Thank you.